We're going to start now with Chapter 11, and in this unit we'll cover Chapter 11, 12, and 13 in Iggy, and then of course all of the corresponding ATI chapters as well. And if you have any questions about which ATI chapters you need to look over, please let me know. At the time of this recording, I don't have access to those books, so I'll have to look whenever we get them. All right, let's start our chapter by looking at how fluid is distributed in the body, okay? Even though there are many types of extracellular fluids and different places where it resides, intracellular fluids make up more fluid volume than the extracellular fluids. Okay? What is plasma? That's the liquid part of blood when all the cells are removed. It carries fibrinogen, which helps with clotting. It has lots of proteins that do different things like enzymes and hormones. Not all hormones are proteins, but many, and it has growth hormones, okay? So homeostasis is where the body is in perfect balance. You're going to have your extracellular fluids exactly where they're supposed to be. That's your blood and lymph. Your interstitial fluids, that's the fluid between the cells. It's going to be in balance like it's supposed to. Transcellular fluids are things like cerebrospinal fluid, synovial fluid, peritoneal fluid, and pleural fluid. All of those things are extracellular fluid, which just means outside the cell. And then you have the intracellular fluid, and you can see here, like we were talking about, the intracellular fluid actually makes up a lot more than the extracellular fluid. Okay, so in that little bar graph there to the left, you've got about 3.5 to 6 liters of plasma, and in the interstitial space, or the spaces between the cells, you've got about 10 to 12 liters. So at the maximum, you've got about 18 liters of extracellular fluid, whereas the intracellular fluid is about 25 liters. And if you like to look at a pie chart better, you can look at the pie chart on the right to kind of get a visual of how the fluids are distributed in the body. So what are solutes? Solutes are the solid particles floating in a fluid, and the solvent is the fluid. Okay, so three-way solutes, which are the electrolytes we're going to be talking about today, and fluids, which is water, travel. So 3 ways that these electrolytes that are floating around in the water travel are through filtration, diffusion, and osmosis. Okay, let's look at filtration first. Filtration is where there is a membrane and there's fluid on both sides of the membrane. But one side of the membrane has a higher water pressure than the other side, and it pushes water across that membrane. You see how the membrane is bowed out to the right there? That fluid on the left side has a higher hydrostatic or water pressure than the right side, and it's pushing water across that membrane. So whenever the hydrostatic pressure on both sides is equal, then there's no pushing of fluids going on. Okay? The goal of filtration is to have both sides equal. The body's constantly trying to seek equilibrium, and when it gets there, filtration stops and fluids remain in their respective areas. Okay, and this will make more sense of how it works in the body as we go along. So here, which way is the fluid going to go? You see how that membrane is bowed to the left? The fluid on the right has a higher hydrostatic pressure, so it's going to push that water to the left, right? It's looking for equilibrium. Okay. So as we said, the water pushing pressure, that's hydrostatic pressure, it forces or pushes that water outward from a confined space through a membrane. The amount of water in any body fluid space determines how much pressure there is there. An example would be your blood pressure. Moving whole blood from the heart to the capillaries where filtration occurs to exchange water, nutrients, and waste products is what blood pressure is. And so we'll talk about that more as we go along. So what is the clinical significance of hydrostatic pressure differences? Well, edema is one that comes to mind. So whenever there are changes in normal hydrostatic pressure, like you might find in right-sided heart failure, you're going to have some edema because they're pushing of that fluid into a space until both sides are equal and that membrane straightens up. Okay, let's go to the next slide and I'll give you a kind of a visual example. All right, this is a box heart, and I like to use this because it's easy to understand. So right there where it says rec in the left-hand upper box, that's your right atrium. Blood will flow down from there into your right ventricle, and then on up to the lungs, and then back to the left upper atrium and the left ventricle. So in this example of the box heart here, I'm showing a rec in the right atrium. Can you see the rec there? Okay. So when there is a rec, you're going to look back one step in the blood flow and you're going to find the symptoms. So if there's a rec in the right atrium or the right ventricle and you back up, that blood flow is coming from the body. So that's where your symptoms are going to be. So if there's a mess up on that right side of the heart, you're going to have fluid back up, and the hydrostatic pressure is going to get higher and higher until it pushes that fluid out into the tissue. And we'll talk about that again more as we go along, and especially when we talk about heart failures. So let's talk about diffusion next. Diffusion is the free movement of those particles, which are the solids, across a permeable membrane from an area of higher concentration to an area of lower concentration. And this is important in the transport of most electrolytes. Other particles diffuse through cell membranes too, but this is most important in our electrolytes. Our sodium pumps are the one thing that, as far as electrolytes are concerned, that works opposite. It moves the solids from an area of low concentration to an area of high concentration. And let's talk about that a little bit more and give you a visual example. If you have two swimming pools, they're right next to each other. One has 80 people in it and one has only 20 people in it. Well, I'm in the one that's got 80 people in it. So I'm looking up and I say, hey, y'all, let's go over there. It's not as crowded. So me and 30 of my friends move over to the pool with a lesser concentration of people. Now it's 50 in one pool and 50 in the other. Now I might look up and say, I wonder if there's more room over in that pool. When I peek over somebody's head and look over there, I see it's about the same. So I just stay put. So this happens with some electrolytes in some areas of the body. However, that sodium-potassium pump, it goes the opposite way. And there is a video that I want you to watch, and I'm going to link it in here so that you can watch it on the next slide, because it won't work in this recording, I don't think. So go on to the next slide, and I'll have this sodium-potassium pump video where you can watch it, and it will really help you understand. You can either go ahead and watch all of this, the current video that you're on, and then watch that one. That's probably what I would do. And like I said, hopefully it'll help you understand a little bit better how the sodium-potassium pump can move against that concentration. Osmosis. So, movement of water only through selectively permeable membranes. That means it's just permeable to water, but not those solids. That's what osmosis is. And what you need to know about osmosis is that water always follows salt. So say that again. I'm going to say it a million times probably. Water follows salt. This is really important when you start to talk about the concentration of body fluids, how many solids it has compared to the fluid the solid is in. So osmolarity or osmolality refers to how concentrated a fluid is. And for the body, we want 270 to 300 milliosmoles per liter in all fluids. In all fluids, we want 270 to 300 milliosmoles per liter, and if they have that, they're considered isotonic, and this is how the body likes it, okay? So let me give you an example. What do you think normal saline's osmolarity is? It's 286.44. So does that fit right into the body's osmolarity? It does, doesn't it? Because it's between 270 and 300. What about the osmolarity of blood itself? It runs anywhere from 275 to 295. So it fits right in that osmolarity per liter. Or osmolality. No, I'm sorry, osmolarity. And the only difference in osmolarity and osmolality, they're really the same thing, but it's how they're measured. So you can use them interchangeably. And the way we're going to talk about them in this chapter is going to be choosing fluids and that kind of thing. So we'll talk about that a little bit more in the next few chapters as we go along, and I think chapter 13 especially. So as you may have guessed, osmosis and filtration can work together. They act together at the capillary level. So you have the capillary membrane, and these two ways of distributing fluid work to keep the extracellular fluid and the intracellular fluid volumes at a normal level. We have a thirst mechanism that's an example of how osmosis helps to maintain homeostasis. So you get a feeling of thirst, and this is caused by activation of the brain cells shrinking in response to changes in extracellular fluid osmolarity. These are osmoreceptors that monitor the osmolarity in different areas of the body. So in other words, the fluid outside of the cell becomes more concentrated. Water flows out of the cell into the extracellular fluid to try and dilute it back to normal. And as that cell shrinks, because the fluids are flowing out of it, it triggers the thirst mechanism in the brain, and the body says, or the brain says to the body, drink, 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 to balance out the fluid distribution. Okay, so let's do that. Talk about that one more time. The fluid outside of the cell in the brain becomes more concentrated because it doesn't have as much water in there. The whole body's getting dehydrated. So it becomes more concentrated with solids like sodium. Water, therefore, follows sodium. So water's going to flow out of those brain cells in a minute amount into the extracellular fluid to try and dilute it, and that makes the cell shrink. And as the cell shrinks, it triggers the thirst mechanism. And the brain tells the body to drink, drink, drink to balance out fluid distribution. So fluid balance is closely linked to and affected by electrolyte concentration. It also has to do with fluid intake and fluid loss, of course. Minimum urine amount needed to excrete toxic waste out of the body is 400 to 600 milliliters a day. So this is very, very minimum amount, 17 to 25 milliliters an hour. So we should be looking for at least 30 milliliters an hour and calling our doc if it's not this much, right? Well, why is that? Because it takes that much to clear those toxins from the body, and the patient will become deathly ill pretty quickly if we don't have that. And we also have to consider in fluid loss, insensible water loss. And this is water loss through the skin, through the lungs, through the stool, and it has to be taken into consideration, but it's something that we can't measure. So that is why we need accurate daily weights, and that is part of how we can measure fluid balance in the body. Can't measure those insensible water losses, but we can get a good daily weight, good accurate daily weight. Hormonal regulation also plays a part in fluid and electrolyte balance, okay? So there are three main things on this slide that you need to know about. Aldosterone. This comes from the adrenal cortex. Aldosterone is secreted when sodium levels are low in the extracellular fluid, okay? So it makes the kidneys reabsorb sodium and water and promotes the excretion of potassium, all right? Antidiuretic hormone is from the pituitary gland, and it's secreted when sodium levels are high in the extracellular fluid, or it has a high osmolarity, and it makes the kidneys reabsorb water only. So you can see why, if the sodium levels in the extracellular fluid are high, that means there's a lot of little solutes in there. It's very concentrated. We want more water in to dilute it, right? Whereas with aldosterone, you're going to reabsorb the sodium and the water. All right, natriuretic peptides. These are secreted when special stretch receptors in the heart are stimulated. And this is the BNP that we look at on our labs, the brain natriuretic peptide, all right? So it's secreted when special stretch receptors in the heart are stimulated. So what disease process would stretch the receptors in the heart, or would stretch the heart enough that these stretch receptors would respond? How about congestive heart failure? Isn't that hypertrophy of the heart, either the left or the right side of the heart or both? Yes, so that brain natriuretic peptide is what measures that. All right, this looks like a really busy slide, and it is, but don't get overwhelmed because you don't have to memorize it. You just have to have a good idea of what's going on here, okay? So this is called the renin-angiotensin-aldosterone system, or RAS. RAAS. It plays a part in the fluid and electrolyte balance and blood pressure. So you can imagine how fluid volume increasing in the vessels will increase blood pressure, right? So in a nutshell, this is what the system has to do with it. You don't have to know this whole system, just know that it exists, and the secretion of ACE, which is angiotensin converting enzyme, plays a part in it, okay? So angiotensin is secreted by the liver. See on the left-hand side of the picture? And it does, and then in response to decreased blood flow to the kidney releases renin. All right? Renin changes that angiotensin that the liver put out into angiotensin 1. Then ACE, that angiotensin converting enzyme, is released from the kidneys and the surface of the lungs, which changes angiotensin 1 into angiotensin 2, and all these other things happen, like aldosterone secretion, this and that. All these things happen, and your blood pressure is increased, okay? So let's think about the meds we give, the meds that end in the word pril. What kind of meds are those? They're ACE inhibitors. So right there, a little bit left to the middle of the picture where we have the lungs and the kidneys secreting ACE, if we block that or make it not work as well, make it not do its job as well, our blood pressure will be reduced. This is also why urine output is used as an indicator of adequate perfusion to the organs. Okay? So don't get overwhelmed with that. Just kind of have a general understanding of how that works. So ACE inhibitors, again, they disrupt that renin angiotensin 2 pathway by reducing the amount of ACE that's produced. Okay, so with less angiotensin 2, we have less vasoconstriction and reduced peripheral resistance, greater excretion of water and sodium in the urine, and by blocking those angiotensin receptors, angiotensin 2 receptors, blood pressure lowers, just like we talked about. So patients with hypertension often take ACE inhibitor medication. Again, you don't have to memorize that chart. Just be familiar with the words on it and the final outcome and and kind of know that this is how ACE inhibitors reduce blood pressure. All right, if we had been doing this in class, we would do phone a friend, but I want you to be thinking about these questions here. Where is the greatest amount of fluid located in the body? Write this in your notes. Right on the top of your notes, phone a friend. Where's the greatest amount of fluid located in the body? What's an example of a solute in the body? If you have right-sided heart failure, why do you have edema in the extremities? Think about that wreck. Go back and watch that part of the video if you need to. I didn't cover this, I don't think, but what acts as a key to open the cells? That's insulin. That insulin acts as a key to open the cells to glucose, and while it's open, some other things happen sometimes. Okay, how does the thirst mechanism work? What kind of med is lisinopril, and how does it work? All right, so I want you to take a little break and answer these questions. Pause the video. Make sure you answer these questions before you go on, and then we'll go on with the rest of this video. This is a really busy slide, but it has lots of information that you need to know here, okay? Dehydration. Who is at the greatest risk of becoming dehydrated? The elderly, maybe the cognitively impaired. Dehydration occurs when fluid volume intake or retention is less than what is needed to meet the body's fluid needs, especially the plasma volume. All right? You remember back when we talked about extracellular fluids and intracellular fluids? Well, dehydration has a lot to do with the plasma volume. Let's start with assessment. We need to assess dehydration by keeping super accurate I's and O's, okay? You need to be assessing that daily weight. And remember that 1 liter of water equals 1 kilogram, that equals 2.2 pounds of water. So if they lose weight, you need to kind of have an idea of how much water loss that is. Remember, liter is a measurement of volume, whereas kilograms is a measurement of weight, as is pounds. Okay, so kilograms and pounds are something you get off of a scale. Volume is something you measure in a measuring cup. Can you measure blood loss in milliliters by weighing linens or urinary output if they wet the bed? I think we've talked about this before, and yes, you can. If 1 liter equals 1 kilogram, then 1 milliliter equals 1 gram. So weigh a dry pad in grams, then you weigh the wet pad in grams and subtract the difference, and that's your blood, urine, or fluid loss in milliliters. Okay? So you need to be able to do that for any math questions that might come up. Sorry about that. Guess what that call is about? My vehicle warranty. Okay. So let's get back to our assessment. So we have accurate I's and O's. We also need to ask questions about home meds. Where would we put this information? On our medication reconciliation form, right? That's going to be super accurate so we can take really good care of our patients. We're going to ask, do you have a history of endocrine or kidney disease? Assess their level of consciousness and mental status. We might ask, are your shoes and rings tighter than they've been? Remember, we're trying to assess for dehydration here, our fluid and electrolyte balance. So, cardiovascular. Plasma fluid volume, blood pressure, and perfusion are all interconnected. Can you see how that would work? If we think about our plasma, which is the liquid part of the blood, and how it exerts pressure out on the blood vessels, that's your blood pressure, and how fluids are diffused sometimes according to that push of the fluids from area to area. So all of those things are interconnected. So when a patient is dehydrated, you will be able to see some telltale signs. Let's talk about what we're going to see and why. Okay? When we talk about the cardiovascular system, one of the elements that we need to understand is cardiac output. Cardiac output is the amount of blood the cardiac system pumps through the circulatory system in 1 minute. Okay? So how are we going to know that? Well, we'll talk about that more in critical care, how to measure it exactly. But to know what your cardiac output is, you have to know how much blood volume is pushed out of the heart in 1 beat. That's the stroke volume. So each stroke of the heart, what is pushed out, and how many beats are in a minute. So stroke volume times beats per minute equals cardiac output. All right, so and as I said, in acute care, we'll talk about that more and more. Normal cardiac output is 4 to 8 liters per minute. Okay, let's see, where are we? Your heart rate increases in dehydration to try and make up for the decreased stroke volume. So we're trying to keep homeostasis. There's not as much volume coming through that heart, and we're trying to get 4 to 8 liters per minute around all the time of blood, trying to get 4 to 8 liters all the time. So instead of So that the heart rate increases to keep that same amount of blood pumping around, the same amount of stroke volume, same amount of cardiac output as we did have. Because the volume is less, our rate is going to be more. All right, so we're going to have peripheral pulses that are weak because there's not as much volume in the vessels to press out against those vessels. And because of that also, we're going to have decreased blood pressure. Let's talk about blood pressure just a little bit. Systolic pressure. What is systolic pressure? That's the amount of pressures in the arteries during the contraction of the heart. Okay? Diastolic pressure is the amount of pressure in the arteries when the heart is at rest. All right, and we're going to have a decreased blood pressure in dehydration. So a decreased pulse pressure is what you will also see in dehydration, and that's the difference between the systolic and diastolic pressure. So you take the systolic number and you subtract the diastolic number, and this normally should be 40 to 60 millimeters of mercury. A lot of times you may see a greater decrease in that diastolic pressure because of the volume decrease. So orthostatic hypotension, just know as your blood pressure decreases, you're not going to get enough blood to the brain. So the patient's going to feel lightheaded and dizzy, right? So what are they going to be at risk for if they're lightheaded and dizzy? A fall. So that's why in dehydration we're so careful with our fall precautions. And their neck and hand veins are going to be flat as well because there's less volume in the body, in the vessels. There's less volume in those vessels. So IV insertion is going to be a little bit tricky on these people. So respiratory changes in dehydration. We're going to have increased respiratory rate. There's not as much blood flowing through the lungs to pick up that oxygen, so we're going to breathe more to try and pick up more O2 and maintain our oxygenation while perfusion is low. If you go to the store and you can only get one package of toilet paper, but you have 16 people in your house, you're going to have to make a lot more trips, aren't you? So the same is true for respirations. If it's picking up oxygen when we breathe in, and there's not enough oxygen, you're going to have to make a lot more trips, so you're going to breathe a lot faster. And this area is actually where you get the greatest amount of insensible water loss. And remember, the insensible fluid loss is the amount of body fluid loss daily that's not easily measured from the respiratory system, the skin, and water excreted in the stool. So the higher the respiratory rate, the greater the insensible water loss. So let's talk about the skin. What's our skin going to look like? We may have poor skin turgor. Do we have tinting? Make sure we're checking it over the sternum and the forehead for older adults. If the dehydration has been going on for any time, you're going to have dry, scaly skin. The mucous membranes in the mouth, they're going to have a sticky coating on the tongue. You may even have cracks and fissures around the mouth, deep furrows on the tongue. These are all related to dehydration. What kind of neurological changes are we going to see? We're going to see a low-grade fever. We're going to see changes in mental status, changes in cognition, and that's more common in the elderly, and actually may be the first indicator of dehydration in the elderly. For every degree, when we talk about body temperature, for every degree of Celsius above normal, a minimum of 500 milliliters of body fluid is lost. So that's quite a bit in a day, isn't it? So that's one reason why we don't let our temperatures get too high, because it increases risk for dehydration. And you'll be, they could run a low-grade fever anyway with less fluid in the body to cool the body. Kidney changes. Of course, urine volume may be decreased. There's not as much fluid in the body total, and also you may be having problems oxygenating the body enough to make the urine like it's supposed to be. Your urine will also be concentrated. So when you look at the urine of a dehydrated person, it will be dark instead of that nice clearish bright yellow. We need to monitor those eyes and O's. Do we see a fluid deficit? The specific gravity in the urine greater than 1.030 is the color dark amber. So daily weights over a half a pound lost per day is fluid loss. 30 milliliters urine out per hour is the minimum. So make sure that you know all of those things about kidney changes that might indicate dehydration. So what will you see on your labs? So on our labs, you might see an elevated hematocrit and hemoglobin. Why? Because of hemoconcentration. So there has been water loss out of the system, but not the solute. The solute is still there. You're going to see an elevated serum osmolarity. You may see an elevated glucose, an elevated protein level. You're going to see an elevated bun, maybe of elevated electrolytes, because again of that hemoconcentration. The water's out of there, but those little solute particles are still there. So when blood loss is the cause of dehydration, hemoconcentration is not seen. Everything is lost at once, the plasma plus the cells plus the electrolytes, okay? So if just water is lost, you're going to see the hemoconcentration. If not, then you're going to see everything that's lost at once, plasma cells and electrolytes. Facts to remember. 1 liter of water weighs 2.2 pounds equals to 1 kilogram. Weight change of 1 pound equals fluid volume change of about 500 milliliters. So you see I've got this in red, this next one. Maybe that means it's going to be on a question. Who knows? We're going to disregard the first half pound of weight gain or loss because metabolism can account for this. So if we said they lost 1.5 pounds, we're only going to say they lost about 500 milliliters because that half pound, we're going to disregard that. So here's another example. If your patient had a weight loss of 2 pounds, that would indicate a loss of 750 milliliters. We're going to disregard the first half pound, so that's 2 pounds minus half a pound, so we've only had 1.5 pounds of actual loss. We multiply that by 500 milliliters, and that gives us 750 milliliters lost. If you don't understand that, be sure and get with me. Physical assessment. We just talked about all of that. Let's move on to patient safety. So we've already mentioned one patient safety issue that you can probably think of for dehydration. What is that? Fall risk. That's right. So we have to ask, are our safety measures in place? We need to educate our patient. Don't rise without calling me. Put their call out in reach. Is their bed alarm on? Teach them to rise slowly and sit down immediately if they become dizzy. So what's the cause of them potentially falling? It's orthostatic hypotension. Or it could be a dysrhythmia for electrolyte imbalance, muscle weakness because of electrolyte imbalance, and maybe even confusion. So there is a potential always for overcorrecting when we're trying to correct dehydration. So that will give us fluid overload. So we need to make sure that when we're trying to get our fluid balance correct by giving fluids, that we assess the patient every 2 hours for bounding pulses, because this would indicate an overcorrection and fluid overload, for shortness of breath, which might indicate pulmonary edema coming on. We have to watch for crackles in the lungs. Those neck veins are flat when you're dehydrated. So what's going to happen if you're overhydrated or have fluid overload? Those neck veins are going to be distended. We're going to start to watch for pitting edema. Is their pulse ox okay? Is it decreased? Make sure that you divide any needed fluids over 24 hours or as the physician orders, okay? Hemodilution can be seen on labs, and we've already talked about that. The H&H will appear decreased because the blood is, we've given them too much fluid, and so that's why that happens. And we're going to talk about fluid overload a little bit more coming up. Further worsening of the condition, which means that the dehydration gets worse, is one of the problems that can happen. So we have to offer fluids appropriate for their diet every 2 hours on schedule. Mild to moderate dehydration can actually be corrected this way. We're going to have our UAP assist us by instructing them to offer 60 to 120 milliliters of fluid every hour or so. Make sure they take time with the patient to see exactly how much they drink. And in more serious cases of dehydration, make sure they're getting IV fluids. Check the IV patency to make sure the fluids are going in. Teach not to withhold fluids to prevent incontinence. This happens so often with the elderly. They stop drinking because they don't want to be incontinent and they don't want to have to get up and go to the bathroom. Monitor your I&Os closely. Monitor pulse quality. Is it still weak? Does it occlude super easily when you try to check that pedal pulse? What's their pulse pressure? That's the difference between the systolic and diastolic. Is it less than 40? What's their weight compared to yesterday? How are those mucous membranes looking? How's their skin turgor? Is it improved from yesterday? Make sure you're getting all the drugs that are ordered to correct the underlying problem. If they have dehydration due to vomiting, are you assessing their nausea and giving their Zofran as it's ordered? Are you checking their electrolytes on AM labs and addressing them with the doc? Are you giving that potassium piggyback in a timely manner and in a safe way? So we have to make sure we're doing all of those things to take care of our patients. So fluid overload, we've talked about this a bit, but you're going to find bounding pulses, shortness of breath and crackles, neck vein distension, dependent edema. So anything that's hanging down, like the feet and maybe the hands, are going to get edematous. They may have reduced urinary output, and it's because their kidneys just cannot keep up with the amount of fluid in the body, or maybe the body's holding on to the fluid because electrolytes are out of whack. You're going to find that they have a decreased H&H and protein due to hemodilution. Their skeletal muscles are going to be weak, and their skin is often pale and cool. So let's turn over to our chart on page 172 and look at it right quick. It's up there in the left-hand corner, and it's about fluid overload. And it just gives you some other things to be looking for. So make sure you're really familiar with all of those things. You may have, I think we've gone over just about everything. You may have altered level of consciousness, a headache, may even get some visual disturbances. We talked about skeletal muscle weakness, paresthesia. You may have gastrointestinal changes like increased motility, which would mean that you might have a little diarrhea going on there. And they could also have an enlarged liver upon your assessment of the abdomen. So what are our interventions for fluid overload? We want to stop it, right? We want to stop it immediately, so we don't want it to get worse. Those with cardiac, kidney, pulmonary, and liver problems are really at the greatest risk because their body just cannot handle that extra fluid. We're going to assess these patients at least every 2 hours, and we really need to assess for skin breakdown and change their position every 2 hours, just like with everybody else. If they can't do it themselves, or even if they can do it themselves, you need to be in there encouraging them and helping them to turn and reposition every 2 hours. So how are we going to fix fluid overload? If the kidneys are normal, we can give diuretics. We're going to watch those eyes and O's very carefully and watch for further weight gain or weight loss. Weight loss is what we're hoping for, right? You may restrict the fluids and sodium in their diet depending on what the doctor orders. Rapid weight gain is the first indicator of fluid overload. So remember, after that first half pound, each pound is equal to 500 milliliters of retained fluid. When we're doing those daily weights, make sure that you weigh them at the same time and lift any tubes or equipment off of the bed if you're using the bed scales. Whenever you have a patient that's going home that is at risk for fluid overload, you need to instruct them with instructions to call the provider for a greater than 3-pound weight gain in 1 week, or if they gain 2 pounds or more overnight. Since electrolyte imbalances occur frequently with dehydration, let's look at some of these electrolytes. We'll start with sodium. What's a normal sodium level? 136 to 145 is normal sodium. Remember, where sodium goes, water follows. Water follows salt is an easier way to say it. Hyponatremia is low sodium level in the blood. Hypernatremia is high sodium level in the blood. So electrolyte imbalance occurs when the dietary intake of electrolytes is kind of out of sync with the excretion of the electrolytes by the kidneys or the kidneys' reabsorption of the electrolytes. So sodium is the solute that determines the osmolality of the extracellular fluid. It is vital for muscle contraction, cardiac contraction, and nerve impulse transmission. So sodium balance is regulated by the kidneys under the influence of those hormones we talked about, aldosterone, antidiuretic hormone, and the natriuretic peptides. Hyponatremia causes 2 major problems, okay? It makes depolarization or firing slower, so excitable membranes in the muscles are less excitable. And number 2, it causes cellular swelling because water follows salt. So let's think about hyponatremia signs and symptoms. Hyponatremia, so if water is following salt, and in the blood there's less salt, that means in the cell there will be more salt than there is in the blood, so the water from the vessels moves from the blood vessels into the brain cells, and this is going to cause stupor or a coma. It's because the cells swell in that brain, water follows salt, salt's low in the blood, so it's higher in the cells, water flows into the cells of the brain and causes edema. So anytime you're messing around with the brain, headaches can be a side effect as well as seizures, right? Nausea and vomiting. Why would this happen? Have you ever guzzled water on an empty stomach? It's kind of like that. You have a big influx of water into the GI tract, and it's going to make you nauseated and maybe even vomit. Lethargy. The muscles have cells with excitable membranes, and because the excitability is decreased, they will be lethargic. You're going to have decreased deep tendon reflexes and you'll be weak. And since we are losing water out of the vascular system, remember our sodium is low in the blood and water's flowing out of the vessels into the surrounding cells, we're going to have orthostatic hypotension. So even though we have decreased excitability of the cell membranes, remember, as long as we're losing copious amounts of water volume out of the vascular system, you're going to see decreased blood pressure. And in response to that, what's going to happen? Your heart rate is going to do what? It's going to go up, right? So you'll see orthostatic hypotension, but a weak rapid pulse to make up for that blood pressure. So your pulse is going to be weak, rapid, and thready, and you're going to always check respiratory effort if muscles are weak. So, because what's your diaphragm made out of? It's a muscle, right? What if you have low sodium with fluid overload? Anytime you have fluid overload, regardless of electrolytes, you're going to have bounding pulses and normal to high blood pressure. So that's the only time you're going to see something a little different with hyponatremia. You need to make sure that you know your signs and symptoms of hyponatremia. Interventions. What are we going to do for our hyponatremia? Well, we have to monitor our response to treatment and prevent overcorrection and fluid overload. We're going to decrease or reduce our diuretics because they can make us lose sodium. We're going to very slowly correct our hyponatremia with IV saline. Okay, if you're giving hypertonic solutions to correct that low sodium, you have to be very, very careful. But you can give 3% or 5% saline. Why do we have to be so careful? Because a quick change in your sodium level can demyelinate the brain. So we also have to increase oral intake of sodium and restrict fluids if that's indicated. So we're going to get the dietary folks involved and protect that skin always. Hypernatremia is a serum sodium of greater than 145. So with hypernatremia, where would the fluid be flowing? Into the cells or out of the cells? Out of the cells, because water follows salt. The salt is high in the blood, so the water is going to come out of the cells into the bloodstream. So we're going to have cell dehydration. So what happens when the cells in the brain are dehydrated? Your patient's going to be restless, confused, irritable, anxious. Their attention span's going to be short. I bet some of you can relate to that. Fluid flowing into or out of the cells in the brain in large amounts can cause seizures. What about skeletal muscles? Muscle twitching and irregular muscle contractions. As muscle cells become more dehydrated, they'll eventually become weaker and weaker. So increased blood pressure because volume is leaving the cells and entering the vessels. You're going to have fluid retention, and it's going to push out that fluid into the tissue, causing edema. All right, so fried salt. Memorize that so that you can know the signs and symptoms of hypernatremia. So what are we going to do to correct hypernatremia? So if the concentration of the blood is high because we've lost just fluids and the sodium is more concentrated because there's not as much water or plasma in the blood, there's more solutes, then we're going to give an isotonic solution like normal saline. If the hypernatremia has shifted fluids out of the cells and into the vascular space, half normal saline is hypotonic, so it'll help the extra fluid move back into the cells. And the dextrose in the solution actually acts because it stimulates the insulin to open the cell, allowing more things to come in. Okay, so that's why the D5 works in that. All right, potassium. The normal potassium is 3.5 to 5. It has some control over intracellular osmolarity and volume because it's the major cation inside the cell. It helps to regulate protein synthesis, glucose use, and storage. And we're going to talk about both hypokalemia and hyperkalemia. Hypokalemia is potassium less than 3.5. Listed here are some types of medications that can cause potassium loss. Lasix, prednisone, albuterol, beta-adrenergic antagonist, as well as N-G-suctioning. Hypokalemia increases the sensitivity of the cardiac muscle to digoxin and could result in dig toxicity. So if you have hypokalemia and a patient's on dig, really need to make sure that you're checking to make sure they don't have dig toxicity. And some of the symptoms of dig toxicity will be GI symptoms. They may have anorexia, nausea and vomiting, abdominal pain. They'll be fatigued, weakness, blurred or double vision, yellow or green or white halos around objects. That's dig toxicity. So if you have low potassium and they're on dig, check for dig toxicity. All right. Ask them if they've had any surgery or been sick. Is that why they're hypokalemic? If they are on potassium, have they been taking it like they're supposed to? And of course, you always need to see how their nutritional history adds up. All right, hypokalemia. Alkalosis. This has to do with vomiting and the way kidneys react to low potassium. It's a little complicated, but in short, the kidneys are stimulated to hold on to bicarb, which lowers the pH, okay? And that's why they're alkalotic. So just know that hypokalemic patients are alkalotic. They'll have shallow respirations because of muscle weakness. So we're going to assess their breath sounds, their work of breathing, the color of their nail beds, mucous membranes, the rate and depth of respiration. They're going to be irritable and have confusion and drowsiness. When potassium levels are low, it slows the relay of messages in the brain. They're going to have weakness and fatigue. So contraction of the muscles is decreased, and this is also why you have decreased intestinal motility. So that backup can cause nausea and vomiting or an ileus, and if it's bad enough, they'll have flaccid paralysis. Okay, their pulse is going to be weak and thready. They'll have orthohypo. Their heart rate can be either very slow or very rapid and irregular. So what is an ileus? I said ileus a while ago. What is an ileus? It's an inability of the intestine or bowel to contract normally and move waste out of the body. And your bowel sounds may be hypoactive or even absent. So try to memorize this little drawing and the signs and symptoms of hypokalemia. Okay, so EKG changes. We're not going to talk about this much right now, but when we get into acute care, we will. Your T waves are flat or inverted, and I'm trying to see which one's pointing at the T. Most of those are U's. You're going to see U waves and ST segment depression. So at the top, I forgot to put that up there. At the top, you're going to see where the T wave is. And I said that the ST segment is going to be depressed. So see where the ST segment is up there? You're going to have flat or inverted T waves and an increase in U waves. So let's talk about what we as nurses can do. We want to make sure we have adequate gas exchange, keep our patients safe from falls, and prevent any injuries from our potassium administration. Okay, we want to make sure we do that safely. We're going to monitor any response to therapy to make sure we don't overcorrect. And with electrolyte imbalances, especially potassium and calcium, you need to have them on a cardiac monitor before doing anything else. So more on what we can do for hypokalemia. We need to learn how to prevent it. So we need to maybe think about recommending potassium-sparing diuretics instead of Lasix. Amiloride and spironolactone are potassium-sparing. And remember that IV potassium is a high alert drug, which means you have to check it with a second nurse. You never, ever, 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 ever give it IM or sub-Q because it's a severe tissue irritant. And you never, ever, 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 ever push potassium. And you don't give a bolus out of a bag either that has potassium added to it. Remember that you should never give more than 10 milliequivalents per hour. And our bags that we have around here are usually 20 milliequivalents in 50 milliliters. So what's the fastest milliliter per hour you can run it at? It's 20 milliequivalents, and we can only give 10 milliequivalents per hour. So it's going to take 2 hours to infuse because we don't want to give more than 2 milliequivalents an hour. It's 50 milliliters. So 25 milliliters an hour, okay? Double check and make sure that you're always running your potassium correctly. So give oral potassium with meals to prevent nausea and vomiting, and we're of course going to collaborate with dietary to teach increased potassium in foods. We're going to do fall precautions for muscle weakness. We may need to do ABGs if it's ordered or indicated. We're going to do hourly respiratory monitoring for severe hypokalemia. We're going to need a pulse ox. Check their ability to cough, and this will give you an indication of their muscle strength. We're going to check for cyanosis in the mouth, the oral mucosa, and the nail beds. All right, it's time to take a break. So before you start the slides, you need to turn this video off for a little while, get up and walk around, get you something to drink, go to the bathroom, eat, take a little 10-15 minute break, and then come back and get started again, okay? So hyperkalemia, neuromuscular changes. At first, you're going to have muscle twitching and paresthesia, which is tingling or burning, and then numbness around the mouth and in the hands and feet. Okay, that's going to progress if it keeps getting worse to flaccid paralysis. Respiratory muscles aren't really affected until the levels are pretty lethal with potassium. Okay, so your teaching plan for hyperkalemia would be diet, drugs, and recognition of the signs and symptoms of hyperkalemia. And of course, we need to collaborate with the dietitian about foods to avoid, which would be high potassium foods. We have to remind the patient that salt substitutes are often high in potassium, so they need to avoid those. And on page 179, chart 11-6, be familiar with the foods that are high potassium and those that are low potassium, and be able to apply those to the diet of people with hypokalemia and hyperkalemia. So you need to be thinking about what kind of foods would you recommend for somebody who has hypokalemia, and what kind of foods would you recommend for somebody who has hyperkalemia. So let's look what a rhythm strip of hyperkalemia patient might look like. Okay. They're often bradycardic, which would be a heart rate of less than 60. They may have hypotensions, but the true thing to remember about EKGs with people, or rhythm strips with people with hyperkalemia, are these tall, peaked T waves. A lot of times they'll have a wide QRS, and they may have a flat or absent P wave, which is what you see on this rhythm strip. With severe hyperkalemia, you're going to see a third-degree heart block, and we'll talk about heart blocks and learn about those a little later. Or they may even go into asystole and code. They could also have ventricular fibrillation, which all of those are life-threatening events. So what do we do for hyperkalemia? We can do drug treatments for hyperkalemia. That's IV calcium, insulin, and dextrose. Why do we do insulin and dextrose to get, do you think? It opens the cells up and helps push that potassium back into the cells. You can do sodium bicarb, albuterol, diuretics. And there's a new drug, patiramir, which binds with potassium in the GI tract. And then, of course, there's good OKX-late. We're going to stop any potassium supplements. That means any potassium in any IVs, even IVs that just have a little added potassium. We're going to stop that. Put them on a low potassium diet. As always, we're going to watch for overcompensation and check those potassium levels to make sure we're not getting them too low. We're going to teach about diet, drugs, and recognition of hyperkalemia. And when the potassium is really high and the patient is beginning to have cardiac symptoms, you're going to treat it quickly with IV meds. It's too late at that point to do oral meds or diet teaching. You need to treat them quickly with IV meds. And of course, since it is it affects the cardiac rhythm so much, you need to make sure they're on a cardiac monitor. Calcium. What's our normal level? 9 to 10.5. Absorption of calcium requires the active form of vitamin D. Calcium is stored in the bones, and calcium is bound to proteins like albumin. Some calcium is quote-unquote free, and this is what we measure in the blood. Hypocalcemia is a reading less than 9, and we're going to ask our patients about their intake of dietary calcium. Oftentimes they'll report charley horses in the calf or the foot during sleep. Have they had any recent bone surgery or bone healing? Have they had any radiation treatments of the neck? Any recent injury to the front of the neck? Hypocalcemia, we're going to have paresthesia in the hands and feet, followed by muscle twitching, painful cramps and spasms. We can have tetany, actually. Trousseau's and Chvostek's sign. I'll show you those on the next slide. Weak, thready pulse. You're going to have a prolonged QT on your EKG and a prolonged ST on your EKG. Hyperactive bowel sounds. You could have abdominal cramping and diarrhea. That's where those hyperactive bowel sounds are coming in. And this of course causes loss of bone density because it's going to be stealing the calcium from the bones to fix the problem in the blood. Okay, so the one at the top, that's the Trousseau's sign, and when you pump up this blood pressure cuff, you're going to have that cramp-like in the hand. And when I think about the Chvostek sign, I always get a little tickled because when I was in nursing school, I had a guy on a ventilator and I thought he was comatose and he had a low calcium level, so I wanted to do this. So I come up and start tapping him on the cheek and his eyes are wide, go wide open, and he's looking at me like I'm crazy, and I had to try to explain what I was doing. So that cheek is Chvostek's sign. Here's an example of prolonged QT and prolonged ST in hypocalcemia. You see the last one here. See how much longer from the beginning of that P wave to the, from the Q wave to the T wave, and how long that ST segment is compared to normal. So what do we do to fix it? We need to restore normal calcium levels by IV or oral medications. We need to give vitamin D to help with the absorption of calcium. And we might need to give drugs to decrease nerve and muscle responses, like maybe they need a muscle relaxer, or nerve pain meds like Lyrica or Neurontin. We're going to encourage calcium-rich foods. We're going to reduce stimulation in the room, have a quiet room, few visitors, low lights, soft voices, okay? We're going to be careful of their bones, lift with the draw sheet, assess for signs and symptoms of bone fracture, which are poor or painful joint motion, unusual surface bumps, and then depression maybe over a bony area. Those all might be indicative of a bone fracture. Hypercalcemia is calcium level greater than 10.5. Mild hypercalcemia can cause an increased heart rate and blood pressure. Severe, or maybe if you've just had it a really long time, you're going to see depressed electrical conduction, which means we're going to have a slow heart rate. So we need to check the blood pressure and heart rate and observe for poor perfusion, which would be pallor or cyanosis, right? EKG with short QT interval. The blood is going to clot more easily when you have a high calcium level. So watch for DVT, pelvic region clots. So we're going to assess our calf circumference, and we're going to assess our feet temperature, color, and capillary refill. Hypercalcemia. Severe muscle weakness, decreased deep tendon reflexes. They might be confused or lethargic. They may have constipation or anorexia because their peristalsis is decreased in the gut. They may have vomiting because of that. Hypoactive to absent bowel sounds. You're going to make sure that you measure their abdominal girth, and you always measure that abdominal girth at the umbilicus, or the belly button. So what do? We need to reduce calcium levels through drug therapy, maybe rehydration, and maybe even dialysis if we have to. So we want to put them on a cardiac monitor, stop all calcium, and you need to think about your fluids that are running. LR has calcium in it. Do we need calcium? No, we don't. So give normal saline to increase the excretion of calcium. Give diuretics that help excrete calcium, like Lasix. You might want to give calcium chelators, and give drugs to prevent reabsorption of calcium from the bone, like phosphorus, calcitonin, biphosphonates, aspirin, and NSAIDs. Watch for QT interval changes, decreased cardiac output, and changes in the rate and rhythm. So you see on the left-hand side, we've got example of hypercalcemia. See how short that QT interval is? Phosphorus, your normal level is 3.0 to 4.5. It's found in the bones, and it activates vitamins and enzymes that assist in cell growth and metabolism. So Calcium and phosphorus are kind of on a seesaw normally, like sodium and potassium are. So when one is up, the other's down. When one is down, the other's up, usually. All right. Magnesium, our normal level is 1.3 to 2.1. Magnesium is critical for skeletal muscle contraction, for carbohydrate metabolism, for ATP formation, which has to do with energy, for vitamin activation, and cell growth. Hypo and hypermagnesemia. These are some ideas of kind of what you can expect if they have hypomagnesemia. I don't know why that's so hard for me to say today. But if it's low, they might be confused. Just all of those things there on the left-hand side. Neuromuscular irritability, tremors, so forth and so on. Hypermagnesemia, they may have flushing, and DTR stands for deep tendon reflexes, okay? So they may have decreased deep tendon reflexes with and that puts me in mind, when you go through labor and delivery, you're going to learn about how to assess for hypo and hypermagnesemia, because they give mag a lot in labor and delivery. Labor and delivery, not delivery. I'm tired as you guys are. Chloride. The normal chloride is 98 to 106. Imbalance occurs as a result of other electrolyte imbalances usually. So if you'll treat those other underlying electrolyte imbalances or acid-base problems, you'll fix your chloride level. So we always want to think about our older people and what kind of considerations. At risk, the older people are at risk for most electrolyte imbalances from age-related organ changes. And also they have less body water than younger adults, so that they're more at risk for fluid imbalances. And of course, they're more likely to be taking drugs affecting fluid and electrolyte imbalances. So your assignment for this, for right now, is going to be to draw the blood flow of the heart. So I want some kind of diagram with the blood flow of the heart that includes the body, the lungs, the heart, and I want you to memorize that blood flow of the heart. Okay, this needs to go in your med-surg notebook, and it doesn't have to be super intricate. You can do a box heart if you want to, but you do need to make sure that you have memorized the flow of the heart. So just to help you remember, it's right atrium to right ventricle to the lungs, back to the left atrium, left ventricle to the body, back to the right atrium. Okay, have that drawn in your med-surg notebook for this assignment.